Hi, my name is Emily Sharpe. I'm an anesthesiologist at the Mayo Clinic in Rochester, Minnesota, and I'm grateful for the opportunity that I have to present to you all today on what I think are the most important articles published in 2024. I have no financial disclosures, and these are my learning objectives. And I only have a brief time with you today. And so, if you are interested in the entire syllabus that I created that has over 177 articles, use this QR code to download the Ostheimer app. I used a search strategy that incorporated searches from Pervez Sultan's 2023 Ostheimer lecture and Dr. Melissa Bauer's 2024 Ostheimer lecture, searching 88 journals. In addition, I used social media and the hashtag Ostheimer 2025 to take suggestions from authors and readers, and then did informal searching on my own. I reviewed over 6,000 articles for title and abstract screening, performed full text review of 600 articles, which resulted in 177 articles in syllabus, and about 20 or so articles in today's lecture. To orient you to the slides, the title of the study and authors can be found at the top, the syllabus number and QR codes in the upper corners. The background and methods of the study are detailed in the middle. The results are summarized at the bottom, and the key points are highlighted above the methods. The major topics in the literature this year came together for me in these following themes. And we're going to begin with what I think is one of the most important topics, maternal morbidity and mortality. Maternal cardiac arrests are fortunately rare, so the opportunity to study and learn from these events is difficult. The seventh National Audit Product in the UK, or NAP7, was a case registry that included cardiac arrest in obstetric patients receiving anesthetic care to give us further insight into this rare event. The definition of perioperative cardiac arrest was 5 or more chest compressions and or defibrillation in a patient having a procedure under the care of an anesthetist. There were 28 cases of cardiac arrest in obstetric patients, representing 3% of all cardiac arrests reported in NAP7, giving us an incidence of about 7.9 per 100,000. There were 5 deaths in these 28 patients, and the causes of cardiac arrest are listed in the table. While only 6% of all NAP7 patients were Black, 21% of OB anesthesia patients experienced cardiac arrest were Black, a significant disparity that should be noted. There are a few key points from the study authors and the accompanying editorial that are worth mentioning. First, cardiac arrest is a recognized complication of spinal anesthesia, and possibly the widespread use of phenylephrine to prevent and treat spinal hypotension may contribute to bradyarrhythmias. Second, an unexpectedly high block may develop following a spinal insert after a failed epidural. And finally, hemorrhage was the single leading cause of perioperative cardiac arrest in obstetric patients in NAP7. When inducing general anesthesia in the background of obstetric hemorrhage, the patient should be adequately and promptly resuscitated, especially relevant when neuraxic anesthesia is being converted to general anesthesia. Next, we're going to move from maternal morbidity and mortality to labor analgesia. But before we completely move on, I wanted to share a study that evaluates the association between neuraxic analgesia and maternal morbidity. Between 2009 and 2018, the incidence of severe maternal morbidity in the UK almost doubled, reflecting the trend of mothers being older, more obese, and with increasing comorbidities. As anesthesiologists, we often recommend a labor epidural in patients with higher risk of severe morbidity. But the data evaluating the efficacy of neuraxic analgesia in reducing morbidity is limited. In this population-based cohort study, the authors linked 6 databases that included all laboring patients in NHS hospitals in Scotland between 2007 and 2019. And the primary outcome was severe maternal morbidity. In over 500,000 births, epidural analgesia during labor was associated with a 35% risk reduction in severe maternal morbidity and a 54% risk reduction in severe maternal morbidity plus critical care admission across all births. These benefits were even more pronounced in women with a medical indication for epidural analgesia compared to those without an indication. Further, there was a 47% reduction in those who delivered preterm compared to those who delivered at term. These results suggest that labor epidural analgesia was associated with a 35% reduction in severe maternal morbidity and particularly noticeable among women at increased risk. Epidurals have many benefits that we know about, including blunting the physiologic stress response to labor, IV access and fluid administration, and avoidance of general anesthesia for cesarean delivery. But women with an epidural also get something else. They get us. They now have anesthesiologists involved in their care, regularly monitoring them throughout their labor course. Further, these results underscore the importance of ensuring equitable access to neuraxial labor analgesia and highlights the importance of supporting women from diverse backgrounds to be able to make informed decisions relating to epidural analgesia. Some studies have demonstrated greater bilateral sacral coverage with a dural puncture epidural for labor analgesia compared to traditional epidural. Most DPE studies have used 26 and 25 gauge spinal needles and have focused on initiation of labor analgesia. Frasinito and colleagues aim to evaluate sacral sensory blockade with a 27 gauge DPE compared to a traditional epidural. And they randomized patients to either DPE or epidural and then looked at both bilateral S2 blockade at 20 minutes and time to achieve a pain score of 3 or less. The DPE compared with the epidural technique had a significantly higher incidence of bilateral sacral blockade at 20 minutes, as well as at 60 minutes. In addition, DPE was associated with a faster bilateral sacral blockade, with the median time to sacral blockade 10 minutes in the DPE group compared to 30 in this epidural group. There were no significant differences in time to adequate analgesia and number of rescue boluses. Also, sacral blockade within an hour of delivery did not differ between the two techniques. Although the incidence of sacral blockade was higher in 27 gauge DPE group, there was no improvement in pain scores for our patients. I think for those who liked the DPE technique, keep with 25 gauge needles. Of note, there was an additional DPE study published last year that looked at the ED90 of bupivacaine to establish labor analgesia and found a 35% reduction in bupivacaine dose, again providing additional evidence that there is transference of medications from the epidural space into the intrathecal space. A common anesthetic option for postpartum tubal ligation is to reactivate a pre-existing labor epidural. Yet there is high failure rate, and many practices in the US have moved from epidural reactivation to de novo spinal anesthesia. This retrospective study aimed to assess the neuraxial anesthesia blockade failure rates for postpartum tubal ligation. And the primary outcome was defined a little bit differently than prior studies because it looked at not only a placement of a second neuraxial block and general anesthesia, but also included local anesthetic use on the surgical field or heavy sedation. For patients who received a de novo spinal anesthetic, they had a 15% failure rate. The mean bupivacaine dose was 11 milligrams for patients who had both block failure and success. In patients who had activation of their epidural, there was a 35% failure rate. Failure rates are markedly higher than the 4% they reported for cesarean delivery in the same time frame. Overall, there was an unacceptably high incidence of inadequate anesthesia for both epidural activations and de novo spinal anesthetics for postpartum tubal ligation. Potential mechanisms could be a lower dose of local anesthetic used compared to cesarean, higher dermatome needed, or postpartum changes. Future studies are needed to determine optimal dosing strategies for spinal anesthesia for postpartum procedures. And since seeing this study, I have started to increase the dose of local anesthetic that I use for these procedures. Evidence-based guidelines on the prevention, diagnosis, or management of post-dural puncture headache is lacking. To fill this void, a multi-society international working group came together to generate 50 recommendations and create this consensus report. The report provides an evidence-based framework to improve prevention, including the use of non-cutting needles for LP, identification, evaluation, when should we be recommending neuroimaging, as well as treatment, including epidural blood patch, and an appropriate follow-up of post-dural puncture headache. Although there is insufficient evidence that the placement of an intrathecal catheter decreases the risk of PDPH and epidural blood patch, the use of intrathecal catheters is becoming more popular. Unfortunately, there is a lack of guidance regarding the best practices to manage these catheters. The Obstetric Anesthetists Association convened a working party to perform a systematic review and produce graded recommendations and statements. They focus on monitoring and management of intrathecal catheters for labor analgesia and operative delivery, as well as safety considerations and complications. Due to the infrequent placement of intrathecal catheters by most anesthesiologists, combined with a lack of standardized protocols, there may be suboptimal delivery of analgesia and anesthesia, as well as an increased risk of complications. Implementation of these statements or recommendations could improve safety and provide a standardization to your practice. An editorial published in IJOA provides a nice overview of these guidelines and provides further recommendations based on recent studies, including intrathecal saline and IV concentropin, as well as highlighting areas needing further investigation. Last, I want to continue with another monumental multi-society consensus statement. Representatives from SOAP, ASRA, and SMFM convened to form a working group to provide practical and evidence-based recommendations for clinicians and healthcare providers, which is focused on peripartum pain management in people with opioid use disorder. A summary of evidence and clinical recommendations are provided, covering 3 phases of pregnancy care: prenatal optimization, labor analgesia, and post-cesarean analgesia. The consensus statement provides a summary of evidence followed by clinical recommendations for each topic covered. And a few important findings are highlighted on this slide, including the importance of antenatal anesthesia consultation, use of neuraxial adjuvants, and post-cesarean analgesia. I can't do this important work justice in the brief minutes we have, but I do recommend you download this article and use the practical and concise information to improve the care of patients with opioid use disorder in your practice by providing an individualized approach to each of them. Sometimes labor fails and we have to move towards cesarean delivery. Intravenous calcium chloride is inexpensive, shelf-stable, and increasing serum calcium may improve uterine contractility. Ansari and colleagues sought to evaluate whether prophylactic 1 gram of IV calcium chloride reduces blood loss during intrapartum cesarean. In this single-center randomized controlled trial, laboring patients undergoing cesarean were randomized to receive placebo or prophylactic 1 gram IV calcium after cord clamp. The primary outcome was quantitative blood loss. The authors had a planned, pre-specified subgroup analysis excluding patients with non-atonic bleeding. In all study patients, there was a 200 ml reduction in QBL. In patients with non-atonic bleeding removed, the reduction was 356 mLs, a statistically and clinically significant difference. There was no difference in major side effects between either group. The results suggest IV calcium was well tolerated and may reduce blood loss during intrapartum cesarean delivery with uterine atony. Future studies should evaluate calcium chloride as a treatment modality for hemorrhage from atony. A follow-up study confirmed a 3-to-1 dose ratio of calcium gluconate to calcium chloride. A recent network meta-analysis suggests that oxytocin, when initiated as a bolus, performed better than fixed-rate infusion, and the international consensus statement on the use of uterotonic medications also recommends an initial bolus of 1 unit of oxytocin, followed by an infusion at 2.5 to 7.5 units per hour. However, the optimal dose of that oxytocin infusion after a bolus is not well studied. So Boonster and colleagues performed a prospective double-blind dose-finding study to determine the ED90 of oxytocin infusion required to maintain adequate uterine tone after an initial oxytocin bolus. Term pregnant patients undergoing scheduled cesarean delivery under spinal anesthesia were included. The primary outcome was satisfactory uterine tone at 5 minutes until PACU discharge. The initial oxytocin infusion dose was 2 units per hour and then adjusted based on the outcome of the previous patient using a bias coin up-down sequential allocation study design. They determined that the ED90 of an oxytocin infusion after a 1-unit bolus was 4.5 units per hour. 18% of the patients in the study received additional uterotonics, and a third developed hypotension. So the authors conclude that a maintenance infusion of 4.5 units per hour provides continued uterine tone in patients having scheduled cesarean, but this is not the patient population that we are most concerned about. Future studies are needed to determine the optimal dose to maintain uterine tone after intrapartum cesarean delivery. We know that twin gestation is a well-recognized risk factor for postpartum hemorrhage and is often excluded from dose-finding studies. So Pesca and colleagues sought to determine the effective dose of oxytocin required to initiate adequate uterine tone in 90% of pregnant people undergoing scheduled cesarean. So they had conducted a double-blind dose-finding study where with oxytocin doses ranging from anywhere from zero point 0.5 to 5 units. And the primary outcome was satisfactory uterine tone at 2 minutes. They determined the ED90 of oxytocin bolus was 4.4 or 3.4 units, depending on the statistical method. One quarter of patients did not have adequate uterine tone at 2 minutes, and the median EBL was a liter. The oxytocin requirement in patients with twin gestation is 10 times higher than singleton patients. And it is currently unknown, but the oxytocin infusion may also need to be adjusted. Current guidelines and consensus statements do not make specific recommendations for uterotonic administration in twin pregnancies, and we need to addend our own oxytocin protocols to include this important finding. However, additional studies are needed to evaluate the safety of this bolus dose of oxytocin. Now, we know oxytocin is the recommended first-line pharmacologic therapy for prophylaxis and treatment of uterine atony, but up to a quarter of cases may require a second-line uterotonic. Methergin and carbapenem are the two most commonly used second-line medications for refractory atony, but there is limited evidence about comparative efficacy. The aim of the superiority study was to compare the efficacy of methergin and carbapenem for treatment of atony during cesarean. In this dual center prospective randomized control trial, patients undergoing non-emergent cesarean received prophylactic oxytocin per hospital protocol. Then, if uterine tone was deemed inadequate, a second-line uterotonic was requested, and participants were randomized to receive either methergin or carbapenem. The primary outcome was the uterine tone score 10 minutes after study drug administration. There were no differences in uterine tone scores between patients receiving methergin or carbapenem, and there were no meaningful differences in secondary outcomes between the two groups. The study did not detect a difference in efficacy between the two drugs for the treatment of refractory atony during cesarean. And so this tells us we can use either agent based on patient comorbidities and drug contraindications, cost, or drug availability. Next, I'd like to discuss a critical issue in our subspecialty. The incidence of pain during cesarean delivery is unclear and varies based on definition. Most studies reporting pain during cesarean have used surrogate markers that suggest inadequate anesthesia, such as general anesthesia, neuraxial placement, or IV medications, but very few have evaluated a woman's self-reported experience of pain. So this study was a prospective observational study that approached patients after cesarean under neuraxial anesthesia to assess their experience with anesthesia care and management of pain. The primary outcome was incidence of self-reported intraoperative pain. 12% of patients reported pain during delivery. For patients having epidural extension, 18.5% reported pain. 30% of patients received IV medications, and the distribution of the types of medications received are detailed in the table by whether the patient reported having pain or not. Overall, 12% of women reported pain during cesarean delivery with epidural extension as a risk factor. Not all women who reported pain received analgesic medications, and not all women received analgesic medications reported pain. This mismatch may suggest a gap in intraoperative communication between patients and anesthesiologists. Nevertheless, the inadequate management of intraoperative pain can lead to traumatic birth experiences, postpartum depression, and even PTSD, and more studies are needed to fully understand the experience of pain during cesarean. The Retrievals podcast, season 2, touches on the experience of pain during cesarean delivery from a perspective of a woman in the US as well as a woman in the UK, and explores some of these issues further. Preoperative fasting is advocated to avoid the anesthetic complications of aspiration. And the labor floor, though, can be unpredictable, and scheduled cesarean can be delayed. ERAC protocols recommend limiting fasting intervals, and a sip-till-send protocol encourages participants to sip water regularly to a maximum rate of 170 mL per hour from admission until their surgery. And this study aimed to compare residual gastric volumes in traditionally fasted versus sip-till-send groups before scheduled cesarean. The cross-sectional area of the gastric antrum in the subtosine group was non-inferior to the fully fasted group in both the right lateral and semi-recumbent positions. Additional studies have demonstrated an increase in patient satisfaction and other patient-focused outcomes, and the implementation of these protocols can be considered. A great resource for gastric ultrasound can be found at the QR code on the bottom of the slide. Moving on to obstetric hemorrhage. The World Health Organization recommends tranexamic acid for all women with a diagnosis of postpartum hemorrhage, but could administration of TXA prior to hemorrhage diagnosis improve outcome? This was a systematic review and individual patient data meta-analysis that used data from 5 large, high-quality randomized trials and 55,000 patients. The primary outcomes were the number of women with life-threatening bleeding, defined as death or surgical intervention for bleeding, and thromboembolic events. TXA significantly reduced life-threatening bleeding, which occurred in 0.65% of the TXA group versus 0.85% in the placebo group. And there were no significant differences in thromboembolic events between the two groups. And so the authors conclude that TXA does reduce the risk of life-threatening postpartum hemorrhage, but there's no evidence that TXA increases the risk of thrombosis, yet these events are rare and the effect estimate is imprecise. The data do not support the administration of TXA to all women to prevent postpartum hemorrhage, however. Next, moving into maternal disparities. Racial disparities exist in the rates of neuraxial labor analgesia use and neuraxial anesthesia for cesarean delivery. So the aim of this study was to evaluate differences in general anesthesia use for cesarean delivery and its indications by race and ethnicity. The study was a retrospective cross-sectional analysis of electronic medical records from over 35,000 patients who underwent cesarean delivery at a single institution. 3.3% of patients received general anesthesia, yet rates varied significantly by race and ethnicity. After adjusting for covariates, Black patients' odds of undergoing general anesthesia were 1.4 times that of white patients. Interestingly, there were no racial or ethnic differences in general anesthesia in laboring patients with an epidural. A second study we discussed today showing benefit of neuraxial labor analgesia. So this study demonstrates that racial and ethnic disparities exist in the use of general anesthesia for cesarean delivery, and Black patients are almost twice as likely to undergo general anesthesia compared to white patients. However, when a labor epidural is present, this disparity is no longer observed. When patients labor with an epidural catheter, this lowers the rates of general anesthesia and mitigates racial disparities. We should focus on patient-centered, timely administration of neuraxial labor analgesia for all patients. I'd like to look at a study impacting the fetus and the neonate. So in the US, neonatal resuscitation protocols recommend direct laryngoscopy for the intubation of neonates. Yet, video laryngoscopy has been shown to have greater first attempt success than direct laryngoscopy in adults and children. And so this single center randomized controlled trial aimed to determine whether video laryngoscopy would increase success on first attempt at urgent intubation in neonates. They analyzed 214 neonates. Successful intubation on the first attempt occurred in 74% of the video laryngoscopy group compared to the 45% of the DL group. And the median number of attempts to achieve a successful intubation was 1 for VL and 2 for direct laryngoscopy. You can see the median lowest oxygen saturation was higher in video laryngoscopy. Video laryngoscopy increases the success rate for first attempt intubation, and NRP should be updated to include recommendations for video laryngoscopy for intubation. And when we are asked to assist with intubation in the living room and we have access to a video laryngoscopy, we should utilize that. Well, finally, we're going to move into our last topic, innovation. In the US, cardiovascular disease is a leading cause of maternal mortality. In Nigeria, the incidence of peripartum cardiomyopathy is 1 in 96 deliveries, which is the highest in the world. Cardiomyopathy can be challenging to diagnose due to similarities between heart failure symptoms and those related to the physiologic changes of pregnancy. A prior study found that an AI-enabled ECG was effective in identifying peripartum cardiomyopathy. So this study sought to evaluate whether an AI-guided screening improves the diagnosis of left ventricular systolic dysfunction in an obstetric population in Nigeria, compared to usual care. They randomized over 1,200 women to receive either usual care or AI ECG screening using digital stethoscopes and 12-lead ECGs. The primary outcome was new diagnosis of cardiomyopathy. The AI-guided screening using the digital stethoscope showed a higher detection rate of left ventricular systolic dysfunction compared to usual care, with 4% of participants in the intervention arm diagnosed versus 2% in the control arm. The number needed to screen was 47. With the 12-lead AI ECG model, the primary endpoint was detected in 3.4% of cases. AI-guided screening using a digital stethoscope doubled the diagnosis of pregnancy-related cardiomyopathy compared to usual care, identifying women who may have other remain diagnosed. The key advantages of this modality in low to middle income countries include portability of the equipment, battery power, and real-time availability of AI predictions. This highlights an important opportunity to leverage digital and mobile technologies to potentially transform maternal care in low resource areas. Cardiac focus use by obstetric anesthesiologists is limited by barriers such as inadequate training. And this pilot prospective trial randomized OB anesthesiologists into two groups, an AI group that received both conventional and AI augmented focus training, and then the non-AI group that received exclusively conventional focus training, with the primary outcomes was frequency of focus use as well as self-perception of image acquisition proficiency. Both groups showed an increase in the frequency of POCUS use and self-perception of skills at 6 months post-training. However, the AI augmented group improved significantly more than the conventional group. So AI guidance can be beneficial in limited resource institutions where local experts and mentors are not readily available. So a few notable take-home points include that prior to conversion to general anesthesia for hemorrhage, patients should be promptly and adequately resuscitated. Neuraxial analgesia and the people who administer them reduce severe maternal morbidity. We should increase the dose of bupivacaine for postpartum tubal ligations. We should consider calcium for intrapartum cesarean delivery and optimize our uterotonic administration dosages. We can use either methogen or carbopro as a secondary uterotonic, and we need to prevent, recognize, and treat pain during cesarean delivery. We know that TXA reduces life-threatening hemorrhage, postpartum hemorrhage, and neuraxial labor analgesia may reduce disparities in general anesthesia rates. When available, video laryngoscopy should be used for urgent intubation of the neonate, and digital and mobile technologies could potentially transform maternal care and clinician education in low resource settings. This is a recording, so I'm unavailable to answer questions during the conference, but please reach out to me by my email or through social media if you have any additional questions. Thank you for this opportunity.